Okay, so welcome everyone to this seminar, which is actually the first one in 2025 of the series of seminars in linguistics that we are organizing. It is a great pleasure for me to introduce Giorgio Di Lorenzo, who is full professor of psychiatry at the University of Rome Tor Vergata. Actually, he's an expert in many fields in psychiatric research. That would be too difficult for me to summarize. And also, since I'm a linguist, I don't have the competence to do such a summary. But let me tell you three fields in which he's a great and renowned scholar. And I will end with the one for which we invited him today. The first one is the study of the complexity behind the phenotypization of schizophrenia. He devoted a great deal of attention to decompose the complexity of psychosis, considering different factors, cognitive factors, personality factors, psychopathological factors. Actually, he told me once that he prefers the term biotype rather than phenotype to capture this complexity. And we know that language is actually one of the fields that might contribute to characterize the complexity of schizophrenia and psychosis. But this is not the reason why we invited him today. The second field Giorgio Di Lorenzo is a renowned scholar in is the translation of research findings into clinical practice. He worked on different training approaches, including a language training, a semantic training, which is very interesting, very important. And he presented it here last year in this room during the discourse seminar that we hosted in April 2024. And actually his presentation is online on the discourse channel. Yes, it is. I will send you the link on the discourse channel. Yes, so have a look at it. It's really a nice training that we are interested in getting more familiar with, and maybe combining it with other training approaches to language rehabilitation that we are working on. Again, this is not the reason why we invited him today. The third reason, and this is the reason why he's here today, is that he is a great expert in studying the EEG correlates of psychosis, and particularly EEG connectivity findings that might be connected with psychosis and schizophrenia. It is, I quote from one of his papers, a study of EEG connectivity is a powerful tool to elucidate the basis of the disorder. But it is in general a powerful tool to understand typical and atypical brain functioning. And we are interested in understanding more about the potential of this technique for application in typical and atypical individuals. So today's talk is meant, that's what we asked him to do, and he was kind enough to agree with our request. It's going to be an overview of different EEG connectivity studies applied to the case of schizophrenia. Thank you, Professor Di Lorenzo, for accepting our invitation. The floor is yours.
Thank you very much for this very special introduction. Brilliant. It's a part of the complexity of my very heterogeneous research interests. The word the case of, because I hope to have the opportunity in the next years to have the case of other disorders other than schizophrenia, particularly depressive disorder, but also post-traumatic stress disorder. These are the three main clinical fields. But as explained, as presented, I have a very, very large conflict of interest in my research activity is the interest of the quantification of something independently from the nature of neurophysiological data or imaging data, cognitive data, behavioral data. As Galileo said, you have to measure everything. We have to try to measure something in order to interpret or to try to order, to understand, to improve the care of our illnesses that we try to care, psychiatric disorders, in general, mental disorders. And the EEG provided me more than 20 years ago with a very, very, with few moments, the opportunity to have a particular view on the brain function. And this is the reason of my presence here. And this type of passion currently drives me each day, each moment, really. This is a very personal, non-comprehensive overview regarding the studying of the connectivity, particularly source functional connectivity. EEG or MEG, these are, I use EEG tool, but I have a very limited expertise also in MEG analysis and not only acquisition of MEG data in UK, Aston University, but also the analysis of a large data set in healthy controls and epileptic patients. But the idea of the use of connectivity in EEG is based mainly on the richness of the. So EEG is has a quantity of data, linear and non-linear data, that we are more than the complexity of EEG is higher than the other neuroimaging tools, absolutely. And when I talk about EEG, I'm absolutely related also to the MEG. But EEG, to acquire EEG, we need only 20 or 30,000 euros in order to have at least 32 channels or 64 channels, depending from the company, from the factory. But we are able to study the complexity of the brain in real time because EEG provided us to have a window on the brain in real time. This is not possible with the PET data or MRI data, independently from the presence of new advancements in the last years. The accuracy, the timing of the timing of the EEG and MEG is absolutely accurate. So we are under millisecond in terms of accuracy. It depends from the sampling rate of the equipment. And the study of connectivity is based on the idea that the brain is rich of connections. I don't have slides about the connectomics because I know that all of you know very well this type of advancement that we had starting from the 30 years ago, so the last 2 decades of the previous century, so 18th and 19th of the last century. And the idea is to obtain a source. No, cambio la sezione. Okay. The idea to study the connectivity is based on the opportunity to reconstruct, starting from the sensor level, the area in the brain that we are able to, in an accurate way, and I try to explain the next minutes how it's possible using a subject's MRI, or template of the brain. So we are able to reconstruct the source of the brain that produce at the scalp level the electrical field. I don't have time, this is not the topic of this talk, but AG has two features on the scalp. First, we are able, starting from a very accurate timing of the brain activity, we are able to observe electrical field on the scalp. And this electrical field is the summary of different networks that in a specific time are connected. The second feature is the frequency oscillatory activity that are the basis of the EEG. So in other words, the EEG is the sum of different frequency, and this is not possible, for example, with MRI, independently from the study of subbands of slow fluctuation of the blood activity that are the basis of the fMRI, but we are able to describe different networks that are correlated or not correlated in a specific brain, in specific frequency oscillations. So the one thing that I want to underline here is that at scalp level, we avoid to talk about true connectivity because at scalp level, the mixture of the signal is very high. So in other words, it's not possible what happened here on the left. So specific sensor that capture a specific area, absolutely no. At sensor level, we capture more than one, at least two, more than two, more than three source. We are able to better identify a specific source if we have specific psychophysics signals, for example, a flash or an image. So there is an activation of the occipital cortex, and with a channel over the scalp around the occipital area, I'm able to capture the activation of that specific sources. But this is not true in general in resting state and in general in the cognitive and the G data during cognitive task. So the most important thing is to have an accurate computation at source level. And this is the main topic that tomorrow you will be presented by Romena Bonnet. This is one of the typical, this image is based on a paper that Romain shared with you with Valentina's group 2 weeks ago, if I remember well. And we have EEG data, head model, if we use a forward solution. In other words, if we have the MRI, we can coordinate over the scalp of each single sensor. This is possible with a simple mobile phone. We capture the 3D image and we are able to reconstruct in a very accurate way, time-consuming way, the coordinates over the scalp. And we are able to reconstruct in a very accurate way different BIM or FEM approach. There are a lot of approach, also Bayesian approach, that allow us to be very accurate in the reconstruction of the sources. This is particularly true for the MAG, because with MAG we have we are able to capture the activation in a very accurate way with an accuracy of 1 to 2 millimeters. With EEG is not so simple, but the problem with MAG is for the deep sources, we have a lot of problem because there is a decrease of the quality of data for the activation of the deep sources. This is not true for the EEG, for example. This is one of the reasons to use also EEG. After this, we calculate based on a segmentation, which is possible with different tools. This step is possible not only in forward model, so a direct model using MRI, volumetric data, subjects, but also with template. The most important thing is to have, yes, the template of sensor level, but the best, based on the literature, is to have the sensor location, individual sensor location. So independently from the presence of volumetric MRI, we are able to segment the data reconstructed based on the reconstructed time series, based on different templates, and tomorrow with Rome you will have part of this complexity, and based on the proper connectivity measure, and I will dedicate 5 minutes on this, we will have this type of image. This is a matrix of correlation. And after this, we calculated independently from the approach measures of networks, yeah, with different type of output. It's based everything on your type of research question. There are different, I apologize for the output, this is a problem, initial compatibility with Mac. I summarize here the troubles that we have with the source functional connectivity with AG and MEG, not only in psychosis, but in general. These are only 3 points: the number of channels and the related problem of forward model inverse matrix, inverse solution, and I will try to summarize this type of problem in the next slides. The use of parcels approach with respect to the Roy-based. Currently, parcel approach, so the identification of in the brain of specific parcel, specific areas based on the segmentation of the MRI, is the classical aspect of one of the classical criterion to segment is the Brodmann area, so based on the psychoarchitectural data. But we have also other type of approach in order to identify, to reduce the number of voxels. So the number of dipoles that we calculate here, because I don't mention it due to reason of time, the identification of dipoles, I can calculate over the MRI template, individual MRI, 8,000 to 30 or 100,000 voxels. So a lot of information. In each voxel has an information that I have to summarize, I have to try to reduce. And this is the question of reduce of voxels. And the last but not least is the connectivity measures. Different physiological significance, and it depends, and I will provide some explanation in next minutes. It's everything based on your research question. This is a tentative 2014, Mahmoud Hassan first name, in the first tentative to explain how is the change of the connectivity, source connectivity, based on the number of channels. Here we have the classical EG model, 32 channels, and a high density EG, 128 channels. With the high density EG, we named 3 types of configuration in a restricted way, only 2. 3 types are 64, 128, 256 channels. In a restricted type, only 128 and 256 channels. But what these authors made, they changed the type of connectivity measure and the type of inverse solution. So the classical, the typical Loretta, as Loretta, but also weighted minimum normal. And as you can see, depending on the presence of high density, depending on presence of the low density montage, we have dramatic differences. At the topographic level, it seems that are not so. So if I'm looking at the moon now, so it seems the same if stay here or in the other place. But looking at measure of complexity of connection, we have a lot of differences. I replicated this type of, an alpha based on 61 channels, and I obtained the same one. I changed starting from 63 channels until 1984 ROIs until I12, and the type of configuration matrices had a dramatic differences. Again, this is one of the most important paper of this, how based on three type different solution, based on four types of connectivity matrices, based on five type of EEG sensor level configuration, how the connectivity, functional connectivity changes in a very dramatic way, but starting from 64 channels to 156, the variability and the accuracy, independently from the type of the functional connectivity measure used, are stable. And this is a good thing for those clinical group or research group that use 64 channels equipment that has in mind to use connectivity. Yes.
So you said that results change dramatically from static with few electrodes to high density, but how is accuracy going?
How?
Yes,
it
changes, but can we say which one is more accurate?
It's more accurate in the configuration of the 256 channels, but we are talking about the accuracy and the stability of the connection, not between two specific areas, but in general in terms of configuration of networks. I don't have time to talk about this, but one of the reasons to use 128 or 256 is stability of the configuration. We are looking, and maybe if I remember well, tomorrow Romain will provide you what we are trying to do in order to characterize the variability, not only in terms of standard deviation, but also normalization of standard deviation. So the variability at individual level is very high, and we have to collect it, and we have to measure. This is not a problem also only of computation. This is a problem of variability. Okay, so and in terms of stability and accuracy, the accuracy and stability is related to configuration specific measures, particularly graph theory based. I hope to be clear about this. I don't have a lot of time to dedicate it, but we are open to question, and maybe tomorrow we have to discuss this. Yeah. There are a lot of reviews in the literature dedicated to resting state, functional connectivity, and general functional connectivity in EEG and EEG. I'm affectionated to this paper because it was the first one, Hildebrand, but also Stam. Stam is a researcher that dedicated a lot of time in terms of summarize the configuration over the scalp of connectivity. So we are not. This is not our friend because we love source connectivity. But in this paper, they summarize 2015, if I remember well, 16 to 15, all the measures that at that time were using in the study of the connectivity at source level and sensor level. But I was affectionated with this paper because here they presented all the critical steps in the resting EEG, starting from the state of EEG, data selection, but also the epoch length, number of epochs, the frequency bands. And I dedicated 1 minute at the end, so close to the end of my presentation, on this aspect. It's a critical point. And the epoch length change a lot independently from the type of connectivity measure, the output, so the results. And not only this last these two steps. These are dedicated to the experimental part. These are dedicated to the analytical or data analysis part. These are dedicated also to this aspect, but is particularly the configuration networks. Also here are listed all the steps that are critical, the filtering, the type of frequency bands, and I even dedicated a lot of time to alpha, but also to gamma, and I will present some results on these, and with Rome we are working a lot on alpha, but not only alpha. And also the construction of networks are absolutely discussed in the not only literature, but also in the scientific conferences, because there are different approaches. Graph theory analysis has a very important position in order to facilitate our work, but this is not always the truth. This is another important paper that summarizes a lot of type of connections, and I want to underline here coherence, and particularly in this paper, and I believe that a part of you may appreciate this, because I'm going now, due to historical reason, I was fascinated to lagged phase synchronization, because the idea that two sources that are not so close in the brain may be affected by a lagged synchronization is true. I also believe, and this is also the truth, that two sources are have a level of synchronization with a zero lag delay. And as you can see on the left, depending on this type of lag, we have a lot of differences in results. Some colleagues believe and demonstrated, for example, that 180 degree, so an opposite phase, is a messy situation, very confusing. This is absolutely true in some situation. Here you have the master Pascal Fries that dedicated in this paper his idea, like a mechanistic approach of dynamics in cognitive activities of our brain, the neural communication through neural coherence, indeed explain in a very brilliant way how this type of synchronization of lag allow an excitation or a spike, because it's present, yes, the spike arriving of the peak of excitability, or the spike missing peak of excitability. So this is very important. If you use a measure with a lag, you are not measuring in that specific moment this type of excitation. This is very important, and Frias dedicated in this second paper 10 years later, if I remember well, 15, the communication through coherence. He was based on very specific visual pattern. He was able to, based on gradual causality, to demonstrate that his hypothesis is true. And also in this, I'm sorry, I missed the paper, 2023, but I will send you. There is another paper published 2 years ago that demonstrated with another type of experiment, this beta gamma or theta gamma coupling with this type of specific synchronization is the basis of cognitive process. Why this is important? Because a lot of you are linguistics. There is a type of specific coherence, direct imaging of coherent sources. It's not possible to mention it in English as a word, but only as an abbreviation, the ICS. And it's possible with this type of approach. This is an image that I believe that here you are able, that you produce it based on response lock and phase lock and time frequency panels. But what is possible with the ICS to compute the coherence? So in this, it's a sort of correlation in specific bands based on the beamformer inverse solution. And in other words, I filtering in a very specific band, and I calculated the coherence sources. And this type of approach is particularly useful for those people interested to study for example, the lateralization process like linguistic one. Yeah. Second part, the case of schizophrenia. I decided to avoid to present all the data regarding the connectivity and what the connectonics in psychiatric disorders, because these type of results are consolidated, but unfortunately, we are not. It's not currently possible to use this type of data in the clinical. For clinical purposes, but only for research clinical purposes, only in research. But the idea to have the EEG in the clinical research, EEG in the research of pathophysiologies of schizophrenia, so primary psychosis, and the terms are absolutely terms, it's primary psychosis. So in other words, more than one pathophysiologist is very, very clear. Another explanation to avoid to use some connectonics images of the schizophrenia or psychiatric disorders is that not all the psychiatric disorders are possible to view as disconnectomics. Particularly for schizophrenia, I believe that is based more on alteration of oscillation. So more schizophrenia is more an oscillopathy than a disconnectopathy, like for example OCD, so obsessive compulsive disorder, or sometimes so depressive illnesses. The case of schizophrenia, I'm asking Don, I'm sorry, Marta, but I have to dedicate 2 minutes to present schizophrenia. And these data are epidemiological data. Schizophrenia is this one, orange here, is more present in male than female in a specific part of the late adolescent, but in male is present later, in the second part of the third decade and between the fifth and sixth decades. But what is the reason? It's one of the reasons to study EEG is this. EEG in schizophrenia start early, during adolescence. And what happened in this phase? A lot of changes in the brain, a lot of changes. And non-specific, but these changes are specific in male than females. And also these type of changes determine the modification or an alteration, psychoarchitectural modification. This is a physiological process based on the pruning mechanism with specific configuration and oscillatory activity. This is the basis, part of the basis of schizophrenia or in general psychosis, a sort of complex illnesses. A lot of clinical phenotypes, but we can summarize here as loss of contact with the reality. And I apologize because this is not a comprehensive definition, but because psychosis is absolutely an alteration of thoughts, perception, an alteration of language.
Can I ask you a question during your talk?
Yes, absolutely, yes.
In the slide that you just, the one I was referring to adolescents,
This one.
I understand the one referring to adolescence.
Yes.
I understand that there is a limit, let's say a lower limit, which is puberty.
Yeah.
And this is extremely interesting for us because puberty is also the very moment where we lose the capacity to learn another language in a spontaneous way. But I was wondering what is the upper limit of adolescence? If there is any marker that you consider in a physiological way, or if it's a conventional limit that you consider.
I don't have a clear answer on this, really. I want only to. I don't have a very specific answer. Adolescents, and particularly, and believe me, I observed this in my two sons. Between 15 and 16, something changes. There are specific expression, genetic expression, protein expression that change the GABA interneuron activities. I don't have the slides here, but there is a specific between 15 and 16 expression of coherence, phase, and other activities related to GABA. Interneuron GABA activities changed a lot in this part of the adolescence, and this is independent. It's more true in male than female. But what is the limit is not possible for me because I'm not a neuroscientist of development, of brain development, despite my interest as a clinician during this phase.
But this observation, I think, at least for me, is extremely important because it may shed a new light on the so-called window period for language acquisition. Since, language is schizophrenia may be related in many ways, your observation plays a central role in that it connects the two phenomena in another way that it's not only the old one observed by Denberg in the late 60s. So it's
I want to create a parallelism with this type of window of acquisition of language. Another problem that we observed is, excuse me, this is not a trivial consideration, this is a clinical consideration. The COVID pandemic changed a lot the way to communicate during in adolescence, late infancy and adolescence. And I observed how the first son that started the pandemic at 14 was completely different from the other one. Despite the sons are like the finger of sense, different basically, no? But the language competency was absolutely affected by the type of connection. So the window that you mentioned, it is similar. This type of window that, excuse me, Mark, we know very well, the window of opportunity. When the psychosis starts, okay? And I agree with you. Psychosis is a complex clinical phenomenon. Psychosis is hallucination and delusion in a restricted way, but all negative symptoms. So a deficit of affectivity, a deficit of motivation, a deficit in cognition, alteration of language, alteration of anxiety, depression, particularly in the first phase, it's not possible to distinguish the depressive and anxiety syndrome to the beginning of psychosis. And what's happening, this is the classical view of this neurodevelopmental disorder, like the first phase of psychosis is, and this is important for our story about the use of EEG in connectivity. Why? Because here we know a lot of potential stressors that change the trajectory of the neurodevelopmental maturation and until the beginning of the first phase of psychosis, with the first episode of psychosis. These phases In these phases, we recognize very well modification at neurophysiological level and structural level that not only predispose to psychosis, but also that determine some symptoms at the beginning. We are interested here, particularly dedicated with a clinical group in Rome, Tor Vergata, but not only collaboration with other colleagues in Rome. The first phases of psychosis, the intermediate phase and the brief limited intermittent psychosis, we are working on these. And why this? Because in this part, we are able to detect a lot of patients that go to schizophrenia, but go also to bipolar disorder, or affective disorder, and behavioral disorder like personality and addictions. A lot of social adversities, they are at the basis of this type of complexity, but I don't have time for this. But these are relevant in order to determine the psychoarchitecture and the connectivity during the first phase, the first 10 years, the first 12 years. This is a very important aspect that we need to have in mind. It's important. And also in this very fantastic cartoon of Craddock and Owen is a summarized a lot of biological and neural models at the basis of pathophysiology of psychosis. I want to go fast, and because the time is going, really go. Yes. Yeah, this is one of the pathophysiological hypotheses at the basis of psychosis. It's based on the alteration at the pyramidal level of the modification of the GABA inhibitory transmission, based particularly on these pyramidal cells parallel with positive interneurons. This type of model is possible to, with this type of model, it's possible to measure specific alteration at oscillatory activity and connectivity in hippocampus, but also in dorsolateral prefrontal cortex in the preclinical model of psychosis. Why is it important to have in mind that psychosis is a neurodevelopmental disorder? Because in the time at the beginning, we have very specific structural alteration just at the beginning that predicts the outcome. And we have also the progression of psychosis depends of the type or subtype at clinical level. At the beginning, we are able to identify some good or negative predictors. And these are the architecture of the connection. So it's very important the beginning phase. I'm going fast. Yes. And looking at the cognitive impairment associated with schizophrenia, and here we have one of the most Italian expert, Professoressa Lucia, particularly the modification of the verbal capacity are present in primary psychosis, independently from the affective or non-affective nature of psychosis. These are relevant. These are based on alteration of connection just at the beginning. And why it's important, this type of cognitive measure, because this predicts the outcomes. I'm going to go really fast. This is not simple. It's not simple. This is not a simple aspect because we have a lot of information, clinical data. We have information based on the potential trajectories. But is it possible to identify specific clinical phenotype? No, it's not possible. Why? Because we are here. We are at syndromic level. We do not have a pathophysiology of schizophrenia. This is true also for depression or OCD or other things, other illness in psychiatry. But one of these aspects that we are trying to do is to look at the phenomenon of psychosis in a different way. And this is important in order to identify different phenotypes, clinical phenotypes, that we can put in relation with our connectivity EEG connectivity measure. One approach is the dimensional one, and absolutely we are able to identify different type of patterns. Another approach is based on the network analysis approach of not the dimensional side of clinical symptoms, but the network symptoms. And this part maybe will provide very interesting results, but not at clinical level, but with at a high order level that I try to explain at the end of this presentation. Another approach is to use a different way to look at the clinical complexity. RDoC is based, excuse me for this arrangement of slides, based on on very specific clinical domains. In this type of approach, the RDoC project, we are trying to measure specific and very high or low order and high order measures that allow us to have measure of circuits, for example, genes, but also self-report measures. Another approach is the synopsis, is based on the classical clinical approach. Three major domains: the affective, the language, and the motor. These are based on the emotions, communications, and motor activities. Specific behavioral and communications of the humans are based on networks in the brain. Another approach is the high-top approach. It is a different hierarchical structure of the psychopathology based on traits until spectrum of symptoms to the general psychopathology. So different type of clinical approach provide us different phenotypes. Why these are important? Because EEG in the clinical practice may be useful, not maybe, but may be useful because EEG is a potential biomarker. What is a biomarker? Biomarker is a quantitative measure that are seen in disease linked to clinical expression and has a very high level of sensitivity and specificity. Imagine that we only two EEG channel on the forehead, and with a non-linear measure, we have the chance to identify with high sensitivity and high specificity those patients with depression respect to controls. So the EEG has a large potential, but this is not the case for schizophrenia. This is not the case for schizophrenia. Another approach in the clinical, for the use of the EEG in the clinical research is the endophenotype. It's a quantitative measure associated with the population, is state independent. So independently from the acute phase to the chronic phase or the remission phase from psychosis, this measure is altered, and is associated is altered also in families of those patients with psychosis. There is a new way in endophenotype 2.0. I don't have a lot of time to explain this, but there is an enlargement of an increasing of this concept, because in the last 20 years, we identified a lot of endophenotypes at neural level, but also in the different inflammatory phagocytic indices, and also in terms of gene expression, and also in terms of behavioral stress-related responses. So the concept of endophenotype is currently more complex than the previous one, but it provides a lot of information. A step back on biomarkers. There are a lot of biomarkers, and EEG allows us to provide, particularly connectivity EEG, biomarker of pharmacoresponse prediction of safety of that for diagnosis, for monitoring. So EEG and connectivity, source connectivity EEG has the potentiality to be very, very useful. Why EEG? Yes, EEG is a very simple, inexpensive, non-invasive, and it has a lot of, provide a lot of information. We identify 4 types of biomarkers in electrophysiology related to diagnosis, related to dimension, to transition in psychosis, and for the outcome. I'm starting from the idea that EEG source functional connectivity allows us to improve the diagnosis. This is the first paper published by Roberto Pascal-Marquis as a first name, and there is also, I want to remember the presence also of Dietrich Lehmann, it is the father of microstates. Yes, in this paper, Roberto, for the first time in the literature, provided this type of information, a decrease in hyperconnectivity in alpha at source level. And after this, there was a sort of replication in alpha 1, but also in theta. And this is a very important paper because in this paper, they studied unmedicated, very unmedicated patients, a limited group of patients, very limited group of patients, as you can see. But the data was were very, very stable and determined this type of trademark, hyperconnectivity in alpha and hyperconnectivity in delta. After this started.
That's a question on this idea of hyperconnectivity in alpha. Was it in a resting state?
Yes. Yes. These are this. Yes, I apologize for this. These are resting state data.
Okay, so it's hyperconnectivity during resting state in general, not in specific ROI areas or.
This is a good question. I'm trying to explain later this. I want to underline that the current analysis that we are doing in alpha based on different type of connectivity measures is not so clear in terms of to confirm this type of hyperconnectivity. It depends from the state of illness. It depends from the type of medication. It depends from the type of measure that the connectivity measure that you use. Here is present source function is lagged phase synchronization index. It's an index of lagged phase synchronization. And we cannot avoid to remember, to have in mind that based on the lagged information, we are looking to a part of connectivity that is not coherent at the same time. So this is not a trivial aspect, because based on my data, and we are analyzing hundreds of patients with schizophrenia at the early phase of illness, so first episode of psychosis of schizophrenia or chronic schizophrenia. This type of information is not so consolidated, so it's not so robust. Another aspect, alpha is a complex phenomenon. Different types of areas produce alpha, not only the classical parieto-occipital area, eyes closed, but also in eyes open. And particularly, we have at least 2 types of alpha activities in the brain and 2 different, at least 2 networks that generated alpha that we can record over the scalp. The low alpha and high alpha, it depends from individual alpha peaks, individual alpha peak. In schizophrenia, in particular in chronic schizophrenia, but this is also possible to observe in the first phases of the primary psychotic illnesses, we have a decrease of alpha in terms of peak amplitude. And depending of the type of the band that you design, you can observe or not observe this type of phenomenon. So it's a bit complicated. The individualization on alpha is particularly relevant, for example, in depression, because depending on the alpha peak, we can change, for example, the TMS frequency of the stimulation during the treatment for depression, particularly the use of frequency that are close to 2018 respect to those that are close to 10 Hertz. So the individual alpha peak is another story. There is a large of that, there are different data sets also present in literature that demonstrated that in those with a high risk of psychosis, particularly those with a high level of schizotypy, present a lower individual alpha peak. So we cannot exclude that this type of variability that we are observing is based on this type of configuration of identification of the band of alpha. In this study, we have, I know very well this study for several reasons, as you can imagine. And we have a decrease in alpha-1 in patients. This is not the same that we are observing. So it's related to the type of connectivity measure. After these two papers, if I remember well, this was 2014, if I remember. Yes, maybe yes. And because Roberto does not love the reviewers, he published after an invitation here in the philosophical transactions. So I believe that he did not receive a very formal reviewer, but this was the first one. But after this, they tried to publish this, but it was not simple due to the number, because the number is very, very low. Okay, but believe me, because I know the groups, this type of schizophrenics are without medication, and medication affect a lot, not only connectivity, but in general the frequencies in the brain. After this, several papers, including one paper that I published in my group with my co-authors, started at the end of the 2014, 15, 16 different papers. The first one was this from the Christoph Müller group with Christina Andreou is the first name. Christina is an expert of microstate, but thanks to a collaboration with Guido Nolte, that is one of the master of the MEG connectivity in neuroscience, they used the particular type of connectivity index, the orthogonalized power envelope correlation. So in other words, they identify the envelope that cover the high frequency, gamma frequency activities. So they identify this type of envelope of the gamma, and based on this, they correlate different sources. This is the basis of this type of this correlation. This is the basis of this measure. And they demonstrated that in psychosis, these are first stages of the schizophrenia. In gamma band, there was an decrease, an increase in this type of particularly left-oriented, left hemisphere hyperconnectivity in alpha at the beginning of the illness. They were able also to identify a correlation with domain, particularly in those with low level of symptoms psychotic symptoms. The same group with a different type of connectivity measure. In this case, they used the multivariate interaction measure, demonstrated that in theta, in the same part of the brain, so left, with a predominant left, increasing activation, so with an hyperconnectivity in theta left, in left hemisphere, in the first episode of schizophrenia. And what is of interest? The correlation with memory function. So in other words, the hyperconnectivity is related with the lower capacity in verbal memory. Fastly, I published in 2015 with my group a very complex study based on lagged phase synchronization, healthy volunteers, 78, 77 schizophrenic patients that I divided in low disease, low duration of disease, lower than 5 years, and high duration of disease. So long duration and short duration. Long duration is more than 5. And I described in a clear way how this type of connectivity is absolutely dependently, is in relation with the duration of the illness. I want to underline 2 aspects. First of all, there is a hyper theta, pardon for the blue, but the blue indicated that that in schizophrenia there is a hyper connection. This is a sort of trademark, but not a sort of trademark because it's present in both groups, with a hyper connection, particularly in long duration. And also in alpha, I analyzed at 8 to 12 hertz, and I demonstrate that there is a decrease in alpha, particularly with the hub in the dorsolateral prefrontal cortex, or in general in the left prefrontal cortex, that it seems it's present there, a connectivity, a decrease in connectivity with other regions in the same left hemisphere, but also with the inter-hemispheric alteration connection, inter-hemispheric ROIs. This seems to be a trademark of long duration of disease, but not in short duration of disease. It seems replicated from based on different type of analysis. It seems replicated, but we need to be more accurate to have the results based on different type of connectivity measures. I want to go fast. The very yes.
Yeah. The relation between the connectivity measure and the symptoms domain, you did not show here. Does it also changes according to the duration of illness? I mean, if
I don't know, because they studied the first episode of schizophrenia, and I don't know if the duration changes. This is a question. This is a question that to answer, we need at least 100 subjects with different illness duration. This is an important aspect, absolutely, because it's related also to the question the consideration about the window during different capacities, changes of the maturation of some capacities. I want to go faster because here we demonstrated that there is in the short duration of disease in hypergamma in schizophrenia. Again, we partially replicated this type, and we are working on this. Sorry. Excuse me. The Muellert group worked on, this is important, the Muellert group worked on 64 channels. I worked on 32 channels. I acquired data for 7 years. After this paper, I started with 64, hundreds of patients, hundreds of controls. I understand that the number of the group is a critical part of the story. So we need to have in mind, in order to obtain robust results, we need a large database. And this is what I'm doing now, what I did in the last 8 years, but what I'm doing in terms of analysis. And I do not present in the next minutes this. This is a reason for the next invitation. But I tried to replicate with the NIRP data, so the Italian Network Research and Psychosis, 27 channels. So not 37, not 64, 27. So, and the number of channels was lower than the present one. But we partially replicated the theta, so an hyper theta. And this is a sort of trademark, an hyper theta, resting state. Theta is 4 to 8 hertz. And hypo alpha, particularly this was true in those with long duration of disease. Again, this is a sort of confirmation of what I observed. No results in gamma, only in beta 1 differences with the higher beta 1, 12 to 20 hertz in a long duration of disease. Results with negative symptoms, so diagnosis. Now, is it possible to correlate symptoms and EEG source functional connectivity? The answer is yes. What we did based on this, on the previous one, so 27 channels, we based on distribution of the negative symptoms, expressive deficit and the motivational deficit, we take the higher percentile and the lower percentile, and we compared these two groups of negative symptoms. So lower negative symptoms, higher negative symptoms. What is of interest is these are unpublished data. We are trying to replicate this data using different type of source functional connectivity, because one of the criticisms that I received as a medical doctor, in an interest in neurophysiology, I don't have a lot of time to work with MATLAB, Python, or whatever you want. So I use Loretta. And Loretta, with the Lagrad phase synchronization, limited a lot the possibility to publish the data, the results, because they wanted the replication of this data with different type of measures, connectivity measures, and we are doing this. What is of interest? This type of high expressive deficit group or lower expressive deficit, or high abolition group or lower abolition group had no difference in cognitive domains. This is very interesting. So no difference at cognitive level, but differences in alpha with an increase in those with the high expressive deficit, but not with in the group with high motivational deficit. So in other words, the deficit of emotionality, the affectivity, so expressive deficit, are related to hyperconnectivity in alpha and with hypoconnectivity in gamma. This is a very interesting aspect. Yeah, we observed when we compared, this is a network-based statistic result. Tomorrow with Rome, you will receive information about the use of this classical toolbox in neuroimaging. This is a classical toolbox for the statistics of the neuroimaging data. And this is because we are working here on the matrices. Okay. Despite the matrices are depicted as ROI in the space, these are the results of comparisons of matrices. And based on network-based statistics, with a correction at network configuration, This is a particular correction. And this is typical in all neuroimaging data. We obtained in hyperconnectivity, the red is the hyperconnectivity, in those with high symptoms of expressive deficit, respect to those with low symptoms. When we look at gamma, we observed a decrease in gamma. So an hyperconnectivity in gamma in those with high expressive deficits symptoms. We use a graph theory to do this, to try to summarize this type of complexity. We use three measures: strength, in other words, he tested the measure of overall connectivity, so the sum of all the weights of the links connected to a specific node, to a specific rod. The clustering coefficient is a measure of segregation, of functional local segregation, and the CPL, characteristic path length, that is a measure of functional integration. In other words, is a measure of connectivity at long distance. What we observed, and only in those with high, expressive deficit, yes, in alpha, if I remember well, yes, we have the presence of more functional integration at distance in those with high symptoms of abolition, but this was particularly relevant here in those with expressive deficit. This is significant. So in other words, in gamma, we observe a high level of integration at distance and in those with high symptoms. This is very interesting. It's a sort of compensatory mechanism. And it's not clear here, but we observed a decrease in alpha. What I'm doing now, I'm trying to explain to interpret how is the effect. I'm going fast in there because the time is a bad friend today. I'm trying to explain, based on the same type of lagged phase synchronization, same pipeline, I dedicated a lot of time to collect first steps of the schizophrenia, and particularly those with a short duration of disease, so lower than 5 years from the first dramatic beginning of the illness with psychosis. So, and I divided those with at least 3 months with the same antipsychotic therapy with, la peppa. With, excuse me.
Can you translate a little bit?
No, la peppa is with first generation antipsychotics and second generation antipsychotics. The number is not indicated, yes, but the first group, the first generation antipsychotics here are 14, if I remember well. These data were presented in the last CIRS conference in last year in April. The second generation is at least in more or less 21, 22 subjects. The controls are 24. And what we observed in gamma, because I'm really interested in the specific mechanism of antipsychotics, particularly prefrontal cortex, in prefrontal areas, that seems gamma related to cognition. I don't present here the data, but it seems, based on these preliminary findings, that the first generation antipsychotics determine an increase in gamma at resting. This is a particular results because if we link these results to the hypogamma that we observe during cognitive task in EEG, we can imagine that the patient at resting has a high level of gamma, and this high level of gamma is not so simple to modulate, to decrease during the task, the cognitive task, particularly working memory task, Steinberg task, or whatever you want. So the demonstration of hyper-gamma connectivity, particularly in prefrontal cortex, and particularly in first-generation antipsychotics, so those people treated with antipsychotics is very, very interesting. Yes, you can criticize me, yes, but who is that use these old antipsychotics? A lot of part of the world, particularly imagine Africa. In Africa, there is the large part of people are treated with haloperidol or with old antipsychotics. In a large part of China, we know very well the discussion of fat, like let's say side effects of second generation antipsychotics, or stiff. So the stiffness is a side effect of the first generation antipsychotics, but both first and second are very, very useful to reduce the psychotic symptoms. So the results that hyper-gamma is related to the presence of first generation antipsychotics, and this can explain a part of the not only variability but the deficit in cognition is very important. I'm completing these results in the next few months. These are not my data. I'm going faster. These are data not recently published, but what is of interest? That this type of approach, this is based on very large database, more than 100 subjects with psychosis with respect to controls. And we had an increase in gamma, as you can see here, independently, but there is an increase now in gamma, in beta. Look at alpha, how is complicated the story, and how is also complicated the story. This line represents a very specific connectivity. So the question is not simple. It depends from the state of, it depends from the type of the treatment, it depends from the illness duration. But what is of interest? It's of interest that if we use a very specific approach, we are able, I'm going fast, we are able to put in relation and this is possible only with large databases, we can put in relation the symptoms, in this case of PANS, with particular expression of connectivity in theta or in beta. And this can be useful, particularly if at the beginning of the illness I have an hyper theta, I can expect that patients may have specific symptoms independently from the observation of the clinic, because again, from an expert clinic psychiatrist or clinical psychologist, imagine that the PANS is possible to measure. PANS is not a self-report assessment, is a clinical administered interview. So it's necessary to have an interview. So the relation between hyper theta and specific symptoms is particularly of interest in those situations where it's not possible to receive a very specific, accurate clinical assessment. What we are doing, yes, I'm going fast, really. We are changing the story because I'm talking about only the static connectivity. Static. EEG is a dynamic. You're talking about static. So you summarize everything, all the dynamic that you are able to observe in one measure that is static. Yes, it's true. In the MRI research area, the dynamic, static, and also the static approach is the standard. We have results in schizophrenia, but also in depression, that the dynamic fluctuation provides different information with respect to the static analysis. It's true. It's a very expected results. Why do not apply this to the EEG? We are doing this with Romain, and Romain, we will present this tomorrow. What we are doing, we take the time series that we obtain after the segmentation and the use of different atlas, we have time series. We apply a sliding window. So in other words, we create matrices for specific epoch. And after this, we are applying the method that is used in the microstate analysis. So the clustering approach, in order to identify specific patterns that we are naming brain network states that are the states in patients and controls. So we put all together, all the subjects together. It's the same that is possible with the ICA approach in the MRI study. It's the same story. We have in this case, we have 135, 46, I don't remember the whole number. Patients are 76, if I remember well. First episode is schizophrenia, based on open neuro database. A part of this data will be presented tomorrow, and you will analyze this data, a part of this data. And we obtained 5 stable configurations that are based on this dynamic approach. And the result that we are trying to publish clearly demonstrated that the static approach and the dynamic approach provided 2 different types of informations, and specific domains, particularly negative formal thought disorder, are related to specific dynamic BNS, so to specific brain network states. And this is maybe, I believe that this is the future, but we have to demonstrate that the dynamic approach will provide other information with respect to the static one. Biotyping erase arrived. What is biotype? Biotypes are these pattern of neurophysiological profiles, so different, distinct neurophysiological profiles. These are based mainly on the objective measure, but they are associated with the different clinical symptom profiles. And this is the basis, not only these are data from TMS and MRI that clearly demonstrate how the use of phenotypes, biotypes, allow to identify the group at the beginning of the treatment that will respond to TMS, respect to we will not respond. Based on this, the BSNP study, independently from the type of diagnosis, schizophrenia, schizoaffective disorder, bipolar with psychosis, determined 3 biotypes. These biotypes were obtained using MRI data, cognitive data, EEG and ERP data. So a lot of data, more than 700 psychotic patients with different type of primary psychosis. And this type of approach allows to identify biotypes with specific neural signatures that are related to different clinical profiles and clinical outcomes. This is the present and the future of our approach. This type of approach allows to improve the accuracy of diagnosis, respect to the use of categories, and this is possible only with clinical symptoms and cognitive assessment and very, very simple EEG data. This type of approach will be absolutely relevant for this, for the early identification not only in the prodromal phase, but also in the early identification will provide us new, different type of treatment approach. Currently, we know that in the world there are at least 4 groups that are collecting hundreds of data in the first episode of schizophrenia. maybe this will be useful, particularly for the study, in my case, of the connectivity. I'm going fast, but also it's the time for normative models. This is an old story that is based on the idea of the quantitative EEG during the 70s decade of the last century. So based on the distribution of the frequency band over the scalp, we are able, collecting hundreds of subjects, to create normative models. This is absolutely interesting because this type of approach is not yet implemented in EEG source functional connectivity. There are two tentatives in bioarchives, one based on the work of the Mahmoud Hassan groups. But again, the idea is the same of the growth chart in pediatrics. So we have normative model of the brain function. And based on this, we are able, this is the hope, to identify specific neural signature and use it based on this normative model. We can identify at subject level what is the trajectory of the development of that subject, looking at that specific EEG neural signature. And in the case of source functional connectivity, source functional SFC, source functional connectivity, it will be very, very interesting in my opinion. Again, what is the idea is to obtain Z-score respect to how he's deviant, this specific subject, based on large database, normative database, and a normative database that provide a normative model of the network functional connectivity configurations. In order to conclude, these are very general comments. The idea is that we need a very high level of synergy between different groups in order to increase the number of our data sets, because this is a very, very critical aspect. And the story of alpha is a very interesting story, and also the story of gamma alteration, so that an increase in gamma source functional connectivity is an interesting story. And it depends from the type of measure, and it depends from the number of subjects. And another critical aspect is the number of channels, because if you have lower low density configuration, imagine 32 channels or 21 channels, you are not able to obtain some specific results. So large database and the use of very high level of integration with different type of expertise, humanities and bioengineering. I'm working with other engineers, and also physicians, like with an expertise in mathematics, in statistics, is a key aspect to try to understand well how we can to move the way to use, the reason to use, and the way to use EEG is changing in a dramatic way. And the use of EEG is justified by the simplicity. Imagine that now in Tor Vergata, I have in Sacconi lab the 256 channels with NET, and we are able in 2 minutes to start the acquisition with 256 channels. And this will change the way of the use of the EEG. But the limitation is that is present only in one center. In France, for example, there are 7 centers with 128 configuration, and they are all connected. And they are working together in order to acquire data. This is another aspect. So I believe that we have to be honest in order to solve, to provide a robust answer. We need to collaborate a lot. Thanks.
Thank you, Giorgio, for this wonderful overview that started from the very basic notions and extended to the frontiers of research in this field. So we have some time for questions. Questions from the audience. Federico Bravo.
Well, thank you for the overview. And maybe it's better that you use nuggets, yes.
Mettiamo quello dal lato esterno.
Ok.
E dovrebbe funzionare, grazie. No.
Thank you. I have a couple of questions that concern the methodology. Going back to the beginning of your presentation, where you mentioned that when you choose and the choices that you have to make, the results might change. So I just have curiosity on the rationale behind your methodological choices on the metrics of connectivity that you use and the source estimation algorithms, whether you run some sensitivity analysis to test the to validate your choices, or you perform multiple analysis and you present them all together in a paper just to give different.
We have to be honest, we use a phishing approach. No, phishing approach is I put in the sphere my attention. No, the question is helpful for me because allow me to provide more details. So I try to explain that depends from your research question. Because if you are interested in obtain robust results, you have to, based on literature, decide to start from one specific inverse solution. So imagine to have EEG data, 64 channels, template of the sensor location, template of the brain, so not individualization, not forward model. So I need to be I have to use robust inverse solution, and the most two robust inverse solution are Loretta family approach. So the approach based on Loretta family, particularly as Loretta and E-Loretta. Recently, another type of Loretta solution was presented last year, 2 years ago, but not from Roberto Vascamarchi. Another is the weight minimum norm. So in other words, you are sure that you will have specific and robust activation. I'm talking about rest activity. Another thing that we do, because I'm a neurophysiologist, not as a discipline, but as a researcher. And one of the things that I do with the new equipment is to record visual evoked potential, some of the sensory evoked potential, and test based on this type of configuration, imaging 64 channel, how my pipeline is able to provide me the activation where I want. We know that E-Loretta or the Loretta family weight minimum norm is robust in determining the cortical activation. The deep activation is not so clear with the weight minimum norm, but are more clear with Loretta. These are the first steps, so the inverse solution. The second is the type of the template. This is not simple. We are not losing, we are dedicating more than 2 years in order to demonstrate in our group that the use of ROI-based, so imagine to have a point, a radius, so you create a group of voxels that is very, very limited in terms of activation and representation of the part of the brain. But the previous data that I published was based on this, and the previous data that the group of Pascal Mackey and the other group used was ROI-based. But now MRI research in MRI research area, MEG research area, the parcel approach is used. So we identify at least two or three templates to test our data. So it's another aspect. So at least two. Another thing is the functional connectivity mission. The first thing is this, that I believe that we have to test three different that are at opposite that provide me different type of physiological informations. So phase locked value, that is really phase locked. Phase locked value. The other is a lag information. So weighted PLI. We use the weighted one because it's one of the most used, and it's demonstrated that is very robust to the conduct volume and also to the partially to leakage issue. The leakage issue is the activation of sources close to those that are of interest for you. This is the leakage problem. And the third type of approach is the amplitude envelope correlation. It's a very different information based on the idea that you have two sources that are correlated based on the envelope of the activation. And we use this type of approach, but we believe that, again, we have to demonstrate this, that the weighted PLI, so the weighted phase lag index, is more robust to provide in at-resting some specific information. This is the idea for you, for your cases, for example, to use coherent sources, because the idea is that you have a very specific process, task, you are reading a story, or if you are observing a specific pattern, for example, you are interested to identify in the identification of specific and coherent sources. These sources are connected, and you, in that case, you use coherence as an index. And this is the case of the ICS, the direct imaging of coherent sources. So it depends from the patients, but in our group with Romain, but not only with Romain, we use at least three types of different approach in order to have a consolidated results. And this is not simple because in a different way, in different situations, we obtain different results. And we have to try to explain this. I hope to be clear in my answer.
Thank you.
Franco Cotugno.
Two very short and from a legal point of view. First one, when you say resting, you mean sleep?
No. Resting state is
without any sensory input, but they are pulsatile, so.
Good question. We mainly use eyes closed. In eyes closed, we have a lot of information related to alpha.
Yeah.
But the best solution that we use when it's possible, and sometimes it's not possible, is the use of both in situations, so eyes closed and eyes open. In order to maintain the vigilance, the best solution is to alternate eyes closed 1 minute or 2 minutes with eyes closed, eyes open.
So in case of the schizophrenic patients, you mean that during the recording they are not psychosis? It's basically, or they have, because what I was interested with the time factor. So I mean, all the images we have seen, it's a sort of average for a basic condition.
Yes.
So we cannot see something that happens when during different phases of the illness. Okay. And I was wondering if fMRI can give you some information on temporal dynamics for the same cases or not.
There are also some results, but not with such source functional cognitivity. But the results are absolutely different. There are, I have some data, but not the database are very, very limited, 21 subjects, and the variability is very high. But again, it's correct. And this is the way to have longitudinal observation in a normative model. This is very important because with normative model, you have the trajectory of the development or you expected a specific activation in a specific phase of the life. But you absolutely cannot avoid to have time zero, so the baseline, but what is the baseline? The active phase of psychosis. It's a bit complicated. So I believe that we need normative model in order to follow this type of changes.
And do you have any studies about people that is normally under psychosis affected, which make a normal life, but talks about with the spirits, with voice, in the inner voices during the...
There is a lot of heterogeneity in our samples because we have people that according to the current criteria of remission has very, very limited symptoms or no symptoms. We have a lot of this, but this is only based on symptoms because if I look the functioning is altered. If I look specific area of cognition, language, these are altered.
My last question, really,
But all these questions are very useful to clarify. You have to clarify this.
All the images you showed us comes from patient without any medication.
No. And I try to explain this. Excuse me. No, this is very important. All this data. I stressed this aspect, but maybe it was not clear. No, was not clear. Why it's important to provide this information about the alpha with the 19 channels, because these data are based on 19 channels. Excuse me, but I'm arriving. Because these patients are not treated.
Okay.
These patients are not treated, this one. But again, look, in Bern, there are 6 women and 3 men. In Osaka, 4 and 5. In Berlin, 2 and 10. So a very limited group, but untreated. These are treated with psychosis. It's the same group, so treated. These from my group are absolutely treated, stable, but the clinical stability and the clinical treatment with antipsychotics is for at least the stability 3 months. And the same here from the NIRC data, so the Italian Network Research on Psychosis, we have the stability for at least 3 months. Okay, but with antipsychotics, during antipsychotics.
Marta Bosia.
I was particularly interested in...
Particularly, I believe that for those that are...
Okay. I was particularly interested in the application for guiding treatment. And you mentioned the example of patient with depression whose TMS was arranged according to the individual alpha peak. And this is a little bit in contrast with the fact that one of the problems is that we have differences only at the group level with a large number with no individual effect. So my question is just a comment on how close you see to the real practice, the application to guide treatment at the individual level.
I promised you to provide some information about this. I believe that currently we do not have the same type of quality of results as in depressive disorders, because depression is a disorder of a disconnectopathy, because we are this independently from the study of alpha as a measure of index of the severity of disease, or an index that can provide us information about the treatment. Schizophrenia is very, very complex. We have at least 2-3 pathologies based on this disarrangement in oscillations. This is particularly true if you look, for example, to the story of the improvement of hallucinations if you stimulate or decrease, the activation with the cathode placed around the temporal parietal junction left and the anode placed around a language area, so close to the dorsolateral prefrontal cortex at left. The idea is not in that case you are modulating a disconnection of the arcuate fasciculus, but you are modulating the prefrontal network and you are modulating another parietal network related to the language. So I believe that it's not possible now to identify an index based on connectivity that is useful for the individualization of treatment. Based on information, we can discriminate those that have a normal alpha or hypoconnectivity in alpha, or the presence of severe hypertheta, because these two are related to cognition. Maybe also the hyperconnectivity in gamma. Based on these, we can try, but this is a tentative that I hope in the next decade to do, to identify those that respond better to a treatment respect to another one. Or, for example, based on the stratification of the connectivity functioning, I'm able to predict those that respond better to, for example, cognitive remediation respect to those that use another approach. So I don't have a clear answer that provides us information for clinical application based on our knowledge, currently knowledge. Excuse me for this. But I believe that the explanation is clear in order to provide how the complexity is of interest for the research, and how is of interest, and particularly for those interested, excuse me for the repetition of the word, to integrate different research fields. I believe that the use of, for example, digital phenotyping, language, and behavioral passive observation, objective observation will provide different phenotype that we can integrate with our knowledge.
There's another question from Giulia Mattavelli. She's the only faculty I didn't introduce to you yet, and she's a professor of psychology here.
Thank you very much for the presentation. My question is, how much do you think that it's related about the present state? So how much the models from a technical point of view, methodological point of view, are also valid for task-based EEG? And it's related to this is the second part of the question is how much do you think the results can drive results for task-based, for example?
This is a fantastic question, because a lot of us are interested in resting state because it's very simple, but resting state provides information to predict the task results, not only at behavioral level, but also at EEG level. Particularly, I started with the quantitative EEG, the 2002, so absolute power, relative power, and so on. But after this, I started with the ERP, visual ERP, somatosensory ERP, auditory ERP that we use it a lot. But the use of resting state is absolutely relevant because it provides a lot of information controlling or avoiding the variability of the experimental context. The unique context that you can consider stable is the auditory one, or the somatosensory activation with electrical stimulation at the wrist. These are the unique. In that case, you are able to have information about the thalamocortical rhythm, for example. No? But with the resting state, you can replicate the same setting wherever you want. It's not the same for the P300, the mismatch negativity, for the other visual paradigms. There are a lot of confounding variables, and this is the reason to study resting state. In terms of prediction, we know that the hypoalpha, or the presence of lower variability, it's an indicator of good, bad performances at the task. Particularly, as I mentioned, the story of the results about the gamma. So the variability of gamma that is not so present in terms of variability in schizophrenic groups is related to bad results in working memory tasks. So the idea, it's another aspect that is absolutely relevant, is the presence of basic oscillation before the beginning of a task or beginning of a psychophysic stimulus, very specific with psychophysic aspect, very, very specific. So the resting activity predict a lot the amplitude of a theta and alpha component related or locked to the event. So absolutely important study of resting. Again, Marta moved a lot in his head when I'm talking about the eyes closed condition. We love the eyes closed, but also eyes open, because eyes open is a condition of, for example, visual stimuli paradigm. And we use the resting state as the baseline for this. And we know very well how this type of baseline predicts a lot the response. So it's absolutely combined, this aspect. There are, in the old story of Everett, the related synchronization or desynchronization, for example, alpha reactivity. So you can, if you analyze it, the alpha, the first 30 seconds after the eyes closed command or eyes open command, you have the reactivity of alpha. And this type of reactivity is related to other tasks, event-related measures or behavioral measures. So the study of resting state is absolutely important, but the problem is the vigilance. And this type of information, connectivity and so on, are affected a lot by the sleep quality, the presence of medication like benzos, anxiolytics, and so on. So we need to be very, very accurate in during the recording phase in order to control with all these type of confounders.
Can I have the last question?
Yeah.
So actually, the overview that you presented really convinced me that when we combine EEG and language, we can really capture more of this variability. But coming to the questions, they were partly addressed during your answer to Marta's question, but maybe I can focus them better. Question number one was on this nice distinction that you draw between oscillopathologies, a pathology at the level of oscillation and a pathology at the level of connectivity. So can you explain better what's the difference, since the connectivity is based on the oscillation? But the second question that might be related to the first one is on the functional meaning of the different bands, of the different oscillation bands. So this alpha and gamma and theta, do they have a functional meaning, at least in the language field, where the meaning of oscillation still has to be fully understood. But a few things are known. For instance, that beta is related to predictive mechanisms in language, while alpha is related more to attentive mechanisms and the accumulation of information during the sentence. So there are a few, let's say, functional interpretation of these components. Is there a way of combining the functional interpretation of the components and the findings observed on psychosis, rather, for instance, specifically reduce or increase hyper or hypo, alpha or gamma, etc.?
Do you want that I start from the second or the first? I start from the first.
You decide how it's better to.
As Marta can support me, because Marta can support me in this type of the first, when we use antipsychotic, after a few days or few hours, few days, we have a decrease of symptoms. This is not possible in obsessive compulsive disorders, not possible. This is not possible in depressive disorders. This is not possible in post-traumatic stress disorder, except the use of specific psychological trauma-focused psychotherapies that work on the psychopathological mechanism that is the dissociation. Because there is delay, the delay of the response of this type of treatment is based on the neuroplastic effect. Because the drugs that we use to treat depression are not drugs related to serotonin or dopamine. These type of drugs determine a change in the architecture. And this is possible after days or weeks, months. Mm-hmm. This is not the same with antipsychotics. Mm-hmm. We know very well if in 1 week on no response, we have to change 1 week at the beginning after 1 week, you have to change because what you are doing in that case with dopamine, mainly dopamine, you modulate different oscillations. Okay. So there is not time to change the architecture. This is the way, this is one of the reasons, in my opinion, to believe that psychosis or primary psychosis are oscillopathy and not connectivopathy. We can discuss this, but this is my opinion. The second question, it depends, because, for example, if you look at chronic schizophrenia with the pharmacoresistance, you have other aspects. But again, this is my opinion. The second question is very important. One frustration that I have is that using, for example, macrostates, using classical frequency analysis, using connectivity analysis, the relations with symptoms and particularly with cognitive performances is very low or absent. And this is important for the question that you asked me. Is it possible to determine a functional aspect of what you are measuring? I don't know. I believe that if during a process like language process, you have an expression of specific frequencies, and these are an expression of that specific behavior or that specific cognitive process. So in that case, I can put in relation oscillations or bands, frequency bands, with the specific tasks. it's not the same with, we cannot translate these in resting state. This is not true. I can provide you a lot of data on 100 subjects. We have no relations except some very general social processes or general cognitive domains. But again, until now, or if you prefer, so far, I do not have very clear relation between a band of alpha, for example, and a cognitive process. We observed two things mainly. The cognitive process are faster in those that have a good expression of specific BNS in alpha. So it's a similar to what you are mentioning. So the attention in general, the quality of the cognitive process is good and the alpha is good. So very general aspect. But the relation with specific aspect is not yet possible. It's a problem. In fact, when I presented this data, this one,
a group that was not different for cognitive aspects, but yet for the...
Yes, for the most expressive deficit. And we can, this is very, very interesting because it depends, maybe it's related to two aspects. The first one, during the EEG or in the same day of the EEG, the cognition was not, in this case, was not measured. So we measured cognition 2 weeks before or after. So the variability. The second aspect is that during a cognitive assessment, the level of participation is not so high. It's not the same with those that you have during the EEG. And this is the way to perform, for example, a cognitive attentive task like, for example, oddball P300 like paradigm in order to have, and analyzing only the correct response. So only in that case you can try to correlate both the resting part and the cognitive task. But the variability is very, very high. And one of the aspects is this. Another aspect is that negative symptoms, I don't want to underline the problem of the issue of the language, but the negative symptoms particularly affect negative affective, so deficit of the emotion expressivity is simple to identify, is a sort of trademark. So the quality of the data, despite these are based on clinical interview with a high level of interrater and so on, the quality of the identification of those with this type of deficit is good. This is another thing that is important to underline. So negative symptoms, as you know, is a sort of trademark of psychosis, of primary psychosis. I don't know if I answered.
You did, and there's a lot of thinking that comes after your answer.
No, but again, thanks because the question of the oscillopathy and circuitopathy is in my mind from several years. And I don't know, I have a lot of data to support one or the other one. The use of antipsychotics is a
main evidence.
Is an evidence of this, particularly at the beginning of illness. And use also clozapine. The use of clozapine in early psychosis, so the psychosis that have an onset between the 18, we have a decrease, I can demonstrate and show this, a decrease. It's incredible the response of this after a few weeks of treatment with low dosages. So, and it's related to a a sort of resynchronization of something that are not synchronized, not to a relational rewiring that is more related to a time question. So I need to have more weeks to activate the neuroplasticity and rewiring the network that are activated. This is my idea.
Jacopo is working with Marta, is doing his study also on close-up and language. So we'll have new data to try to test this hypothesis. But anyway, Giorgio, like you said, there will be a next invitation, probably next year, where you will follow up on these studies and the new results that you have. And for now, thank you very much for this.
Thank you again for the invitation.